at least.
At least what? For how long?
At least for
At
the
least.
project's presentation.
Okay,
and,
good.
maybe one of my colleagues will stay with you all the time, and we will have a separate meeting as you.
Sure, we will do that.
Maybe we should just ask if everyone's okay with us recording also. Is that okay? Just
I don't know if we started or not. We started recording, right? Yes.
It started, yeah.
I hope you don't mind. Okay, just a formal good afternoon from Cairo. And I'm just saying how thrilled and honored that you are with us. And I'm looking forward to the remaining experts that will be joining us as well. We are a small group and we could have gone around the room to introduce each one of us. But I was thinking during the open discussion, before your intervention, if you want to say a few words on the type of work you're doing. I mean, we know who you are and you know your expertise, but we don't know what you're doing recently, if it connects with some of our work so that we know what each other is doing and we can really join forces. That's the objective. I will hand it over to my dear colleague, Jocelyn, who is the partner here in this work. And you start us off, Jocelyn, and then we'll move to Shireen presentation before we open the floor.
Okay, great. So thanks everyone for joining. I'm talking to you from Beirut at the American University of Beirut. And I just wanted to say from the beginning that this has been a wonderful partnership that actually has historical roots. So this is a project that is very much initiated and really mostly carried out by the American University in Cairo Social Research Center. And for complicated reasons, I think to do with research in the Middle East and some of the constraints on it, we are actually, the AUB is actually the recipient of the grant from the IDRC. But so this is really a dual act here and a partnership, as I said. It's interesting when you look at the history of these two institutions. Our Faculty of Health Sciences, which is basically like a school of public health, but is a Faculty of Health Sciences, one of an independent school in an independent faculty within the university. It dates from 1954, and the Social Research Center was actually founded in 1953. So I think that in itself is really interesting that these two institutions in two parts of the region have been conducting social research, public health, well-being kind of research, and very much focused on inequities all those years for those decades. And I just want to also just say that I've known Huda for also decades because I used to work in Cairo during the time in the 1990s at the time of the International Conference on Population and Development. And I remember well the first days when she developed the first course ever in the region on reproductive health. And in the region there was really interesting research which informed the International Conference on Population and Development about reproductive health, women's health. Huda Zarek and other colleagues who really conducted seminal research that brought the world's attention to the whole issue of reproductive morbidity. And then another part of the historical background to this meeting, of course, is this report that you see on the right there, which is the social dimensions of health report for the region. And again, there's a part of partnership here because our former dean at the faculty, Dr. Iman Noueh, had served on that commission, as of course did Huda. And Huda's really, this whole project really grew out of that work. So, but of course, there's a wider team, and we have Shireen and Zainab who will be hearing today from, and they're very much, doing most of the work behind this project. The funding for the project comes from the International Development Research Center, of course, in Ottawa, in Canada. We have an advisory board, and we've already been meeting with the advisory board. We also have country coordinators. So, for example, we have in Jordan, Dr. Kariman Al-Zain. And then in each country, Jordan and Morocco, and we'll come back to why we chose those countries in a minute. But we also have national researchers who've already been churning out some research. Research assistants, so Maram, Mariam, Mohammed, and Amr, and I think they're with us. And then postgraduate interns as well. And the research assistants and the postgraduate interns are based in Cairo. So, you're all familiar. I don't need to give any background on the social determinants of health, but just to take this quote from the EMR report, that inequities in the conditions in which people are born, grow, live, work, and age, and what we label the structural drivers of these conditions, political, economic, cultural, and environmental influences, produce inequities in health. And at least I think we all globally now, that is finally recognized. And if there's anything that has reinforced that even more, it's the COVID pandemic. And given the limitations, same report, given the limitations in data availability, one of our most important sets of recommendations relates to the development of effective national data systems for reporting on these health inequities and for regular monitoring. And it's really that recommendation that this project grew out of, because that's what it's following through on. And it's arguing for policy level change and pointing out that existing data, the data that we do have in this region, like so many other regions, does not make visible in any way the inequitable distribution of health conditions, and does not link inequalities in health threats to unfair social arrangements. And of course, here is where the justice aspect comes into it. And development discourse and initiatives in the Arab region also specifically do not make the connection between gender norms and reproductive health. So it tends to be almost a technocratic approach to reproductive health. And so the discussion around changing power dynamics, cultural values, and discriminatory practices is just not there on the agenda. So as you will already see, we have chosen to focus, although it's a wider discussion on the social determinants of health, to focus in on the whole area of gender norms, reproductive health, sexual and reproductive health, and how this influences health. So the potential then to start from the problems, but now the potential is to try and build on existing data. And again, this is really important, that there is in this region, like so many other regions, there is lots of data collected, whether it's in terms of survey data or existing health information systems, et cetera. But it's often not done with much of a design in mind. And the idea here is to use existing data and our knowledge of the region to show that we can address the social determinants of health, and to use this micro experience in 2 countries of the region, Jordan and Morocco, to advocate for wider adoption of this approach. And again, with starting from a health information system, if it's adequately conceptualized, it can be actually used to look at this unfair distribution across social groups and the role of context. And again, coming back very much to the gender norms and how we need evidence to reorient policies in this respect. So why the EMR? And of course, we are in the EMR, so that's maybe our story, but what would the EMR have to contribute to wider global debates on these issues? Well, first of all, it's been a region that has been slow to acknowledge, at least in the development of public health discourse, the importance of the social determinants of health. Or at least it's not necessarily adopted in media discussion or in public debate. Those of us who work in this field, of course, this is very much our bread and butter and what we always focus on, but it's not necessarily widely endorsed. And ministries of health in this region really don't take a health equity or even human rights approach whatsoever. Very strong focus on curative services, tertiary care, and to the detriment of health prevention and promotion. And of course, this region is interesting also because it hosts some of the richest countries as well as some of the poorest countries of the world. And within those countries, we have huge international inequities. And I won't name names, but there are countries in this region where there's just an enormous disparity. And of course, this region has unfortunately had a history of a massive conflict and forced displacement that we're still very much living through. But overlaid on that is massive migration into the region and out of the region for voluntary reasons, for economic, educational, and other reasons. So a country like Lebanon, where I live, has had flows of refugees, Palestinian, Iraqi, and now Syrian refugees. But overlaid on that, voluntary migration and then out migration. And so very complex, demographic profiles and And in many parts of the region, not enough discussion of how this health information systems and the data that we have reflects the non-nationals who are resident. So whether they're refugees or migrants, etc. And of course, also, unfortunately, a huge political and economic upheaval. So then why Jordan and Morocco? Well, interestingly, both countries have very good health information and data systems. Both countries have regular nationally representative surveys. But we also have very good collaborations in those countries. So among this larger team, previous and recent research in Jordan, good collaborations in Morocco. Both countries have recent census and other relevant data to draw on. And we're happy, and actually there's been even further development on this in the case of Morocco, but we're very happy to have the buy-in of governmental bodies in both settings. So I won't spend too much time on this slide because I think we're preaching to the converted here, but as we all know, the social determinants of health are complex and force us to go out, way upstream to all of the factors that might affect health. And so this is drawing on the WHO's framework of Solar and Irwin. So diving right into the project, and you'll be hearing more of it and more detail later on from Shireen and others. But basically, we have 3 phases to the project. And this image on the right, by the way, is the SRC kind of. I see this on your website. It's a nice way of kind of all the complexity, and we're sort of an eye on the world. So the first phase of our study is the conceptualization and development of indicators, and you'll be hearing a lot about that today. The second phase is engaging the pertinent stakeholders in Morocco and Jordan, which we've already started on. And then the phase 3 is wider regional dissemination and outreach, as well as documenting all that we've learned. The key objectives, we have sort of 3 parts of it corresponding. So we have, guiding policies through proposing information system for health that allows looking at some of these health inequalities across relevant dimensions. Expanding the coverage of the information system, and we really see this as going well beyond the health sector to capture, necessarily so, to capture some of the structural determinants. And then developing capacities to manage and utilize this health information and other data to inform policies. And above all, giving visibility to these social inequalities in health within specific contexts in order to sort of stimulate demand for this kind of analysis. So again, starting just at the level of 2 countries, but hoping that this will generate some more interest and wider uptake. But then we also want to focus in on particular programs, and what we plan to do is select specific SRH programs in these 2 countries. And then, as I've said, bringing in the gender and rights dimension. And then really disseminating this, and this has already begun, and Huda might say a bit later about the SDG platform, and we'll show that in a minute. But we want to disseminate our thinking about this as we begin this, so not just at the end, so that we can share this, what we're learning. So 2 key outputs. First, support the transition from a healthcare preventive model led by the health sector to a health equity promotion model led jointly by social and health sectors. So really moving beyond the health sector. And the second, support reproductive health programs to incorporate these missing social dimensions of health that I mentioned are so missing in the region. So year 1 activities is producing comprehensive data that health and non-health stakeholders can use for making evidence-based decisions. And here you'll hear very concretely and specifically from Shireen about this, but proposing a core basket of national level indicators that allow for the measurement of some of these health and wider inequalities. And already we've generated some outputs, and so there's a background paper, there's a review paper on the health information system in Morocco, there's a review of social determinants of health and the extent to which they're included or addressed in the current system of health information in Jordan. And a package of indicators package of indicators and measures to monitor health inequities and guide policies. This is by Shireen and Huda and Zainab all on the call today. And then a summary report, which you received with your materials for today's meeting, which includes the package of indicators and measures to monitor health inequities and to guide policies. So you can see that the team has been busy, and you can also see that the scope is ambitious. This gives you some information about the website. We'll share all this information with you. And that's really all I wanted to say, just to sort of introduce the project. The timing of what we sort of estimated what this would take is for Shireen to present the work to date and the thinking that's going on for a little more than half an hour, and then opening this for discussion, although I imagine that Shireen wouldn't mind taking questions and comments as she's going along, and then just closing remarks. So we aim to finish by 5 o'clock our time, which is in about an hour and 40 minutes. Just wanted to end with pictures of our two settings for those of you who are far away. So on the left is the Faculty of Health Sciences at the American University of Beirut, and on the right is the newly relocated, well, I think of it as new, it's not so long now, it's maybe you think of it as old now, Huda, but the relocated American University of Cairo campus. Because when I was living in Cairo in the 1990s, the AUC was downtown Cairo. And so this is, to me, the new campus. So that's our setting, and that's a little bit of a background on the project. And we look forward to the discussion.
Thank you very much, Jocelyn. Very clear, and you really started us on the right foot. Before I hand it to Shireen, I just want to say a couple of words. The first is, and I don't want to put Dr. Radwan on the spot here, but as you notice, in Morocco, we don't have yet a coordinator, and we're hoping to attract Dr. Radwan to serve as the coordinator, but we'll talk to him and we'll invite him later because we want him on this project. The second is that Jocelyn talked a lot about a package of indicators for the sexual reproductive health and how gender will figure very, very as key determinant here. We have developed this package of indicator, but it's not subject to our discussion today because we felt we don't have enough time to do it, but we will be posting it on our site. And of course, all your remarks will feed into any revision to the package for the SRH. Now I move to my dear colleague, Dr. Shireen Shawqi. Shireen is the leader of this scientific work. I mean, it's a collaborative effort between all of us, the team, but I must credit her. She has done all the hard work behind it, and we came to critique what she did and change a little bit here and there. But thank you, Shireen, for your work. And of course, we'll hear from the experts and revise it accordingly. So she'll only discuss one output, which is the indicators, the national level indicators. She's not going to be talking about other outputs. Shireen, the floor is yours.
Thank you, Dr. Huda. Hi, everybody, and thank you for joining. Let me first introduce myself. My name is Shireen Shawqi. I work as a senior scientist in the Social Research Center of the American University in Cairo, and my background is in public health. Please don't believe Dr. Huda, I was not the only person working on this project. It was really a teamwork, a lovely team work. Maybe we had hard times, but still it was really fascinating work. If you just permit me, I will stop my video so I have a better connection, and let me share my screen. Okay, it's my pleasure to present before you our work in our center. I will try to be brief so we have enough time for discussion, but in case, as Justin said, you have any pressing question or comment, please just jump in and make your intervention. As when it's my problem when I present, I don't pay attention to chat or to raised hands, so please jump in. as I told you, I will try to be brief, but we are really counting on your input for that, and we want to make the best out of this opportunity, having you with us. I will present the package of indicators and measures that we have developed in SRC to guide monitoring health inequities. So let's first agree that it is evident that health is no more the business of the health system alone. It is a whole of a national responsibility. And being certain that the conditions in which people live influence their health implies the need for comprehensive data. We need to move the data from just from just looking to the biomedical model or focusing on the biomedical model that serves monitoring health policies and interventions to be able to guide the full package of social policies and interventions. Actually, this was seen in the SDG vision, which speaks to the intimate linkages between health and the other 16 goals. We have seen that there are health indicators spread all over the goals, not only SDG 3, and the COVID-19 pandemic came as really as an illustrative model for this vision that alert us to this interlinkages and to the need for actions and policies for health and well-being. So actually, we all feel that there is a pressing need to generate data and information, not only to monitor health, but to monitor inequities in health. And by this, the problem is raised. Actually, monitoring inequities in health is completely different from monitoring inequalities in health. And monitoring inequities in health implies the application of an equity lens, which is not just about measuring inequalities. It is about detecting these inequalities and tracing them back and linking them back to their root upstream forces. And this requires not only saying that these social stratifications differ in health outcome. No, it requires that we link the distribution of health inequalities to the distribution of their determinants along the multi-level pathways of influence. And to do that, we need summary measures to show us the degree of these distributional inequalities across the social stratifications and to help us in investigating the fairness of the upstream forces that have shaped these inequalities in health. Actually, if we want to move from monitoring inequalities in health to monitoring inequities in health, we have to find measures that go beyond the overall national averages and the simple disaggregations to describe the distributional inequalities, which will help us judge the fairness or the unfairness of the upstream forces and of the national services in a country. And this is the work that we were focusing on, and we stressed on 3 social structures that can help us show this unequal distribution in health and link them to the upstream forces. And I'll speak about these structures more in details in the coming slides. Now, when we went back to the literature to see if we have these data needs fulfilled in the literature, actually we found wealth of literature on that, wealth of reports, wealth of data sources speaking about that. And we really recognize them all, we appreciate them all, and we are building on them. But still we found that there are gaps in all these efforts. And by the way, what you see in front of you on the screen are just example of the key landmarks among others. The gaps that we found is that they focus on specific indicator domain, not on the full package of comprehensive data. They either focus on the health system indicators, or they focus on the social determinants of health. And when it comes to measuring inequalities in health, they simply rely on the simple gap measures, despite that the same literature speaks a lot about the limitations of these measures, especially when it comes to monitoring trends or to identifying magnitude of inequalities. And this gap was what we wanted to fill in our work. So our goal was not to focus on the health system needs only. We wanted to produce the data that respond to the needs of the health and non-health stakeholders and can help in guiding the package of policies and actions for health and well-being. And we thought, do we really need such information? We found that actually such information is very important because it will alert countries to the need for equitable healthcare interventions. It will help in strengthening the stewardship role of the healthcare system and permits driving an intersectoral action for health and health equity. Most importantly, it will emphasize the social accountability for health and well-being, and it will mainstream an equity lens and fairness lens for health and well-being. Our focus was the production of this comprehensive data specifically for Arab countries. So, what do we really need? We need a core basket of national level indicators and measures. And we specifically want these indicators and measures to measure health and health inequalities, to link them across the lengthy pathway to the root structural causes, and to identify the groups experiencing higher risk of ill health. But if we stop here, this is not all, because this is already what exists on the ground. This is the traditional way of looking to the social determinants of health, what we call the inequality approach. But if we want to move one step further, we need a social determinants of health inequity framing, an inequity approach that help us trace the unequal distribution of health to the unequal distribution of the population by the different stratification of the social structures, link them to the unequal distribution in the public health, in the public services, including the healthcare services provided, and link them to the upstream root causes. So what we did is that we moved in a very systematic approach. The first thing we said we need a monitoring framework for social determinants of health inequities, not social determinants of health only. And we want to identify the indicators that can be hosted in this framework to measure, to provide comprehensive measurement for health, its social determinants over the long pathways. And we also need to look to the summary measures for these indicators. And at the end, we compiled all this information in 7 tables that you have at the end of the report that we have shared with you. So let me start from the beginning. What have we done? The first thing that we have done, and thanks to Jocelyn, she has showed you, or she has reminded you of the Commission of the Social Determinants of Health framework. Actually, the framework that we built is founded on the Commission of the Social Determinants of Health. We did not do much changes in this framework. Actually, what we were trying to do is to operationalize the Commission framework to be able to monitor health, social determinants of health inequities. What we were looking for is developing domains that can accommodate the different indicators. And we came out with the domains that with the 7 domains that you have in front of you, moving from the structural forces as inputs to their manifestations as social structures as outputs, and then to the outcomes in the living experience that end in health. And we had a second pathway from the inputs to show the importance of the healthcare system, of the other systems in improving the health conditions and the contextual factors for people, and responding to the differentiated needs of the different social structures. Okay, let me just take you step by step and quickly on each of these blocks, and what did we do exactly? How did we move from the Commission framework to this social determinants of health inequity framework? So the first domain that we wanted, the first indicator domain that we looked for was the impact. And this was very straightforward. It was health. And when we looked to the literature, we found that health is always assessed in terms of survival, mortality, morbidity, and disability. So this was very straightforward. When we came to the outcomes, we found that the Commission framework speaks about two levels of outcomes. The first is the individual factors, and we split them into two indicator domains. The first are the individual risk factors, and we kept the psychological, behavioral, and biological classifications of the Commission, but we added to them the nutritional risk factors, as we found in the literature that they always speak about nutritional risk factors as a separate category. And for the second indicator outcome domain, this we tried to clarify or explain more the material circumstances in the Commission framework, and we have put indicators domains to clarify them. These were the household, community, city, and city characteristics, the national services, the conditions at work, and leisure. Actually, our contribution here was just that we are calling or stressing on the need for producing national level indicators, overall indicators, disaggregated indicators, but also on the addition of a distributional summary measure for these indicators. And the outcomes here, we call them the proximate determinants to health. When we came to the outputs, we still used the social structures or hierarchies defined by the Commission of Social Determinants of Health. And we have identified the spatial context, which is measured by the, which represents the geographic areas that reflect clusters of health influencing forces. And in the literature, this spatial context, there is a proxy for measuring it. This is the geographic administrative location, which is very much appealing to policymakers. And this is how they distribute the resources and services. The second is the social class that has some economic basis and command over resources, which influences health behaviors and health outcomes as education, as income, as wealth, and many and others. But actually the literature speaks about wealth as a proxy for this social class, especially in countries where income is not available. Our true contribution here was the introduction of the culturally constructed context. And by this, we mean a context that reflects the power and discrimination that manifest themselves in the surrounding of people and influence their health. And actually, these cultured contexts manifest themselves as ethnicity, as gender, as race, or any stigmatized groups. This culturally constructed context is not available for in the literature. And we have taken an illustrative example for that. We developed a gender context index that can help in assessing the culturally constructed context, and which moves from most to least restrictives. It actually describes the gender norms, related behaviors, attitudes, and practices in a certain geographic area. And actually, the significance of this is that it can be easily measured on area level without the need for population-based surveys. So this was our contribution in this output indicator domain. When we come to the inputs, we still used the Commission of the Social Determinants of Health Framework definition for the structural forces, with the governance, the regulation, the policies, the laws, everything as inputs that affects the production of social structures and influence their life experience and ends in health or differences in health. Our contribution here was the addition of a force indicator domain relating to emergencies and shocks. And this was important to see if the countries have inputs that allow them to be prepared to fight or to overcome the health influences of these emergencies and shocks. And we stressed on two disasters that we already see, which is the climate change and the response to the epidemics. Now, we have also introduced a new domain for indicators, and this domain we called the intervening forces, that we defined as the healthcare system, any other systems that affects the context in which people live, the enabling environment, and the social cohesion. But when we came to monitor the intervening forces, and first to monitor the healthcare system, which is a key player here, we did not find any definition in the Commission framework. So we found a WHO's health system strengthening framework that helps monitoring the healthcare system. And this framework makes use of the outcomes and the impact to assess the performance of the healthcare system, and the outputs, the inputs, outputs, and processes at the level of the healthcare system to measure its capacity. So we said we will monitor the healthcare system in terms of performance and in terms of capacity. But actually, when we came to find or to organize the indicators for the capacity, we did not find a framework. We did not find this in the health system strengthening framework, but we found it in the building blocks. And we said that we will measure the health system capacity in terms of the capacity of 5 of its blocks: the service delivery, the health workforce, the information, the equipment, and finance. And we left the governance as a separate indicator domain. We did this for 2 main reasons. First, because of the very important leadership role of the government in addressing health challenges, in addressing healthcare inequities, in advocating for health outside the healthcare sector to steer an intersectoral action. And the second reason is to differentiate between the governance of the healthcare system and the national governors when we come to organize the indicators. actually, for the other systems, the same framework can be used to assess their capacity and performance, but here we only focused on the performance of the other public systems as an indication to the role and responsibility in the production of health inequities. We also focused on the practices of the enabling environment and on the social cohesion. Actually, we developed this indicator domain because it is intimately related to health by three pathways. First, directly influence the health impacts. Second, it helps in the promotion and prevention of diseases by addressing the individual risk factors. Third, its capacity and its availability, accessibility, affordability, and quality of the services in the context in which people live help a lot. And the last pathway is through the responsiveness to the different needs of the different social stratifications. And this applies not only to the healthcare system, but to all the intervening forces. And at the same time, they are influenced by the upstream forces. It's the inputs of the upstream forces that manifest themselves in the capacity and the performance of these intervening forces. So here we wanted to differentiate from the upstream forces as only inputs to their manifestations as outputs in terms of social stratification and as outputs in terms of manifestations in the capacity and the performance of the intervening forces. Okay, we finished out with our framework. We have our framework ready. We went now to the choice of the indicators. The first thing that we looked for, what is the regional commitment? The first, that is a commitment for all countries, are the SDGs. All countries need to report on all indicators of the SDGs. The second commitment that we found is the WHO AMRO list of indicators. We took the WHO AMRO list of indicators as almost all Arab countries are present in the Eastern Mediterranean region except 2 or 3. And certainly these 2 or 3 has other commitments that are similar to the Eastern Mediterranean region. So we compiled these committed indicators. Then we went to all the global reports that recommend indicators, the WHO for the health system, the global indicators for the health and the other social factors, and specifically to the reports of all international agencies. We also looked to the data sources available, to the population-based surveys and the data they provide us, to the observatories, repositories, dashboards, any data source that you think of, the national statistics in Arab countries, and we found a very interesting resource, which is the Arab Development Portal that produces indicators for all Arab countries. It displays, it does not produce, but it displays indicators for all Arab countries that come from international or from national statistics. After that, we assembled all these indicators. I can tell you it was hell of work. We've assembled them on an Excel sheet, and this has allowed us to review them, to remove the redundancies, and to just look critically at the indicators, find the gaps in them, and propose new ones. We also look to the metadata of these indicators to see how are they measured? What are the summary measures used for these indicators in order to standardize them and use a standard definition for the measurement, and at the same time, see if these measures, these summary measures are enough or we need something more. We compiled all these indicators and started organizing them on the different indicator domains in our framework. I hope we did a good job in doing that, but we still feel that maybe this organization needs revisiting or needs some modification. But we tried our best to organize them, starting from health impact to upstream forces, complete, comprehensive. We did not focus on one domain. We had all the domains in front of them, in front of us, and we organized the indicators over them. Now we came to the summary measures. We found that the summary measures that are used for indicators, either overall averages in the form of counts, ratios, proportions, rates, whether measured as crude or standardized or probabilities, to provide the or identify the priority national challenges. And these measurements are very important to alert countries to their priorities, not only in health, but also in the social factors. The second type of measurements that we found was disaggregated data to identify the risk factors or the determinants that affect health and to identify those most at risk of health. And this was just to find the inequalities between groups. It is true, it is important because it guides the national interventions to address these risk factors at this level to improve, to promote health, to prevent diseases or to provide curative care. But till here, we cannot speak about inequities. If we want to move to assessing inequities, we need other measures. And these measures are the distributional measures. The literature displays many of these distributional measures. And actually what they do is just that they compare the distribution of ill health on the level of the proximate determinants or on the level of the health system with the across the different stratification of a social structure with the population distribution across the same social structure, and gives an inequalities distribution measure at the end that provide the magnitude of this uneven or unequal distribution. So it helps countries in ranking priority inequalities in health. It helps them. It helps also in monitoring trends and in comparing between countries in terms of inequalities, and it links this unequal distribution to the fairness of the upstream forces that have shaped them. And two measures are available in the literature and out of our work in SRC that do this job greatly. This is the index of dissimilarity and the concentration index redistribution needs. So our contribution here, and as I have mentioned before, that we are stressing on the need of adding a summary distribution measure to the aggregated data and to the overall national averages if we want to move from inequalities to inequities. Okay, we've put all these indicators. We ended up by 198 indicators that we have organized over the 7 indicator domains that you have seen in our framework. It's true that this is a very long list, but actually this is a sort of comprehensive data that we need to fill in the full pathway from upstream forces to income, to impact. And what we are stressing for that in these 7 tables, we are calling for disaggregation by the relevant determinants, as well as by adding a distribution inequality measures. I will just go, you know, this, we really need your input on the 7 tables, but I know that this is a long thing to discuss in this 2 hours. So I will just go over the 3 tables or the part of the tables that we feel we specifically need your feedback on them, because till present we're not really comfortable about the organization or the indicators that we have put in this tables. And these are the three tables that we will talk about are the indicators for the contextual forces, the healthcare system indicators, and I will focus on the capacity and on the governance of the healthcare system, and the indicators for the structure forces. The other tables, they just display indicators that are straightforward, that are found in the literature, and maybe they just need simple revisiting for organization. But these three tables that we will focus on are the ones that we really specific, it needs more critical thinking. The first table, the contextual forces. We have, as I told you, we had three subdomains to host the indicators. The first is the household and the community characteristics. The second is the public services that are present in the context. And the third are the conditions at work and leisure. And we found indicators in the SDGs that can fit, and even in the national statistics that can fit in this three indicator sub-domains. We have only proposed one extra indicator. No, we have proposed just two extra indicators for that. The stratification for these indicators are available in the SDG list and in the AMRO list. But countries are welcome to use the disaggregations that they want. And we also want a distributional measure to be added to these indicators. If you can just scan them quickly with your eyes, if you have any comment on them, or just write it down, and we can discuss it during the discussion after I finish my presentation, except if there is something very pressing. Just for the organization, the relevance for this block, the relevance to reflect the contextual factors in which people live that are the outcome or that differ by the different social structures. Okay, I will move to the healthcare system, and here we will focus on the healthcare system capacity and performance. The capacity, as I told you, we looked for the capacity of 5 out of the 6 building blocks, and we found indicators. They're mostly AMRO indicators and SDG indicators that can fit in this indicator domain. Just scan that quickly, see if the indicators that are available here are well organized and this is their place or not. When we come to the governance, the healthcare system governance, that is completely different from the national governance. The national governance are the inputs, the policies, the laws, the regulations for the whole of the nation. But their manifestation on the level of the capacity of the healthcare system governance is what we have added here. And still, if you can just scan them quickly, we only found one SDG AMRO indicator for this. We tried to add 4 more indicators that can help us assess the healthcare system governance, and the others are present in the national statistics of countries. So if you can also scan them quickly, and then when we come to the discussions, we can discuss them together. The last is the structural forces. And for this, I have 3 slides. First, the governance of the structural forces. And please, when you review them, when you review these indicators, just think that these are the inputs. The outputs and of the governments and the outcome of the governance are not at this level. They are at the level of the structural, of the structures, the social structures, or at the level of intervening forces. So what do I have as input on national level that influence the production of social structure and influence the public services and the public interventions? And these are mostly at the level of the governance here, they are mostly SDG indicators. We just try to add one indicator to that, and they only refer to inputs. For the policies, we focused on the economic, the health, and the social policies. To see them as inputs, and they are mostly also SDG and or AMRO indicators. And here we tried to add few more indicators that can help in measuring or in assessing the policy level inputs in a country, whether health or social or economic, but they influence the production of the social structures, they influence health, and they influence the national services. The last slide, this is my last slide, is the culture, traditions, and selected and societal forces. We also found SDG and AMRO indicators that can be put here or added to this indicator domain. We proposed one extra indicator for that. And we have also found indicators in SDGs that refer to the climate change, and we've added an indicator to represent response of the national response to epidemics. Okay, this is my last slide. We know that we are proposing 198 indicators. Actually, all these indicators are either commitment or they are available in the national statistics of countries, of Arab countries. We have proposed very few ones that you can just count them on your hand, with your hand. We did not propose many more indicators. It's just what is there. What our contribution was just to organize them over the full breadth of a social determinants of health inequity framework and to find the relevant summary measures, whether as overall averages, as disaggregated averages, or as distribution average. What we are just saying is that this is an aspiration to cover the full breadth of the framework and provide the kind of evidence that policy makers need for better policies for health and well-being. Countries need not take the full list. They need to think critically of the indicators that are most relevant to their context. If they find something missing, they can add more. If they find something not relevant, they can just forget about it. But all what they need to do is to provide overall national averages, to provide the disaggregated averages, the disaggregated data, and to provide the distributional measures to capture the full context for better health and well-being for all. And thank you very much. I hope I wasn't too long in my presentation. And Dr. Huda, the floor is yours.
Thank you, Shireen. So my task is easy. It's really to listen to you and to hear your comments. But what I try to do here is to organize the comments and divide them into 3 blocks. The first part that I'm inviting you to intervene is, first, of course, if you have any clarifying questions or you would like to share your general impression. Basically, the question on our mind, the logic that we are proposing in order to identify the indicators and assign them to different domains, we need to hear your reaction to it. Do you find it reasonable? Also, more importantly, how new is this work? I mean, we are doing this work, we feel there are bits and pieces, lots of work everywhere, but we feel that it has not been brought together, gelled together in a systematic way. So from our perspective, we feel that we are contributing to the discourse and to the issue of monitoring equity. However, maybe you know better, maybe there are other efforts that is similar to ours or even better than ours. So let's open the floor in relation to a general feedback. So could you raise your hand or just come in, because we're a small group. I'm looking at if anyone has raised their hands in the reactions. Can I invite anyone to give comments?
I can start.
Sure, go ahead, please. Go
Ahead. Hi, I'm Laura Magaña. I'm the president and CEO of ASPPH, which is the Association of Schools and Programs of Public Health. And it's my great honor to be here among colleagues that I have known for several years. Some even members of our association. So I'm very proud of the work that you're doing. Really, I'm so really impressed today. But also I have recent colleagues from the 3D Commission that it's really a great honor to be here, and also knowing new colleagues as well. So first of all, I think I'm really extremely impressed of this work. So thank you very much for deeply, I mean, you can tell there's so many hours here and thinking, and people, it's just an amazing amount of work. So I agree that for me, looking at now at the amount of the work that it's here, it definitely I can see that, yeah, you are contributing. My answer will be yes, you're contributing to the field, just because I can see here that you not only kind of summarize everything that was there, which you did. I mean, you actually, put together everything that it has done in this field, but you are contributing to some pieces that are fundamental nowadays. So in particular, I want to mention that, for example, for me, one of the most important contributions that I can see in your work is that the part about the culturally constructed part, that's key. And the other one that you said, emergencies and shocks, that we can see now with the pandemic, and now, unfortunately, with the war, so important that we need to have it in our framework. So putting together in a already complex framework, all these pieces, I think that part is the good part. And I think that you are really contributing and just adding to have a very comprehensive part. Now, having said that, so my first reaction, as you were organizing here, our thought is just, I really, congratulate the work, and I do believe it's really innovative the way you are presented here. However, when we go to the feedback and maybe the future steps, I do have some feedback in very specific in some of the indicators, but also I'm more concerned now about moving forward with these, because I can see that now it's just adding more complexity. So comprehensive, that's good, but then how would be like the next steps in order to not we don't want the governments to feel like overwhelmed of this. And I know that one of the next steps was you pick, whatever how you want to proceed. But I think we need to discuss a little bit more that like folding all these complexity in the countries. But I think that just from the first reaction, the general impression, I really congratulate you for an excellent work, and I think you are adding to the holistic view of inequities. So thank you for that.
Thank you very much, Laura, and I will invite you when we get to the second part and the third part. Does anyone else would like to share a general reaction? I see raising hands. Dr. Nazar, do you want to start?
Thank you very much, Professor Huda. And first of all, I would like to thank you for the invitation, and also for Dr. Shireen and Dr. Zainab, because they also invited me to attend the previous workshop. And without attending those workshops, it will be difficult for me even to digest this incredible piece of work that I'm really proud of. And also, I guess all of us, we are proud of such work like this. Actually, I work in the Ministry of Health in Sultanate of Oman in issues related to health system policy and planning, but also I have some interest in community-based initiatives, which are mainly addressing the social determinants of health. And maybe Professor Huda didn't know me very well, but I was one of the, member in WHO country office in Iran when we hosted the third commissioner meeting in Tehran at that time. And so from that time, I was following this work as far as the SDGs, social determinants of health, is concerned. And I guess it is the first time for me to feel that now we are trying to materialize and to put our dreams in realities, because before we are always talking about conceptual frameworks, but I guess this one is a really practical framework that can be applied, and also we can see the result in the future. So congratulations. I have general observation and also some general suggestions as well. And I would like to start from the point that Laura mentioned previously about the added item which has been added to the inputs, which is related to the pandemics and the climate changes as far as crisis is concerned. And I want to link this part with the intervening forces as well, because some of the intervening forces are related to the health system and health system performance. And I would like just to suggest that in order to shift from the traditional way that WHO and countries, they are trying to assess the performance of their health system, now after these pandemics and crises, now I guess the health system resilience should be addressed more than the performance, because resilience here will address this input as well. And we will find that most of the indicators that has been mentioned in the health system performance in terms of capacity, the government and performance, actually they are now encompassed in the health system resilience framework. And also that framework goes beyond the traditional way that WHO and countries, they monitor their health system. And I guess this will be an added value to this framework. The second issue is related to the overall number of indicators. And I guess Dr. Shireen was a little bit worried about 198 indicators, but I want to reassure her that out of these 198 indicators, actually 102 are related to the health system, either to the health system impact or the healthcare delivery indicators. That means that those indicators are almost existing, and which they constitute almost like 52% of the total package of indicators. And I guess we should not be afraid or worried, because we should try to utilize what is existing. And if we have more than 50% ready, then I'm quite sure that the remaining 50 are either available or we can generate in the future. Just two challenges, I guess they will try to face us in the future. The first challenge for this conceptual framework is how we can start from now this transformational process of the mindset of the health policy, decision makers, in order to shift from the traditional way of dealing with things to this new concept and framework, which is more comprehensive, and they can give them everything into detail, whether at national level or at subnational level. This is the first challenge, and I guess our work should go hand in hand with some orientation in order to try to change this traditional mindset. The other point I want to say also related to our existing health information system. When I see this framework, it comes to my mind that now also our health information system needs a very dramatic change from facility-based health information system that we have to go now beyond the health facilities in order to see and to get information and data from where people live, work, play, learn, and educate. And I guess this is the real challenge for our health system, how we can go beyond our health, the boundaries of our health facilities. Thank you so much, Professor Huda. And again, millions of congratulations to this incredible work. Thank you.
Dr. Nazar, thanks to you. And you reminded me of a very nice memory of Iran. It was really historic visit. All your comments are very, very well appreciated. And the whole idea of the health system resilience framework, will look into it carefully. And also, actually, I think a parallel effort that needs to happen is that we should look at what exists already in the information system. We try to do that for Morocco and for Jordan, because those were the two countries of our focus. But I think it's really important, because the more we find health information system collecting this data, the more ammunition to us to convince other countries to adopt this system. Thank you very much, Dr. Nazar. I'll move to Salma.
Yeah, hello everyone. Well, just like everyone said, I think this is impressive work. And before I just provide some thoughts on why I think this is really a clear contribution and something that hopefully will be pushed publicly soon, because a lot of other efforts are coming behind this, I think in the next year or so related to this work. So my name is Salma Abdallah. I'm a medical doctor from Sudan, and I think Dr. Nazar is also from Sudan, just if I'm not mistaken. And but I was the project director for the 3D Commission with the Rockefeller Boston University on social determinants of health and data. So I think this is really important, because when we finish the 3D Commission work, the next step the Rockefeller Foundation is actually pushing us to do now is, can we find a way to move from the what to the how we can operationalize social determinants of health? And their main push is actually very much relevant to, can we find indicators people can actually agree upon and countries can move forward on? And with that, I think the main issue and main challenge we're finding right now, and I think this is what Laura was talking about as well, is that we're having a tension between having something that is complex enough to actually show the complexities in different countries, but at the same time, we're being told you need to start with something that is small enough for countries to actually adopt. So we've been in conversations with the Health Systems and Policy Alliance on whether we want to start with a 3 points indicator system for countries to see if that would hold off. But I think what you've done here is just beyond that in so many ways. But I think that's the challenge that we're actually having the discussion on it now. The only country I think that I've seen something similar, and I'm happy to share the document if I find it, I think there was a university in Australia that tried to do something similar for Australia that came out end of last year. And I think that might be also just helpful to see other efforts, even though they're countries that are from different socioeconomic status, but I think that's a relevant indicator. Another one, and I think we'll get into the indicators later, but I think another effort that you might find relevant is the World Economic Forum is also trying to create a set of indicators for action on social determinants of health that both countries and the private sector can use to advance their work on social determinants of health. So that's also coming up soon. And I'm happy to share the documents on those. The last one is the, I know the World Health Organization now, their update, and you're probably working with them, but their updated report on the social determinants of health is actually going to come out on inequity as a major component of looking at the social determinants of health. And they're also looking to try to find a way to establish indicators for social determinants of health globally. So the report will come out end of this year. I think the indicators, the hope is like by next year would be out. So I think if this comes out earlier in the process, that would actually be helpful to a lot of other processes that are happening. I have specific feedback on the specific areas within the framework, but I think generally speaking, I'm just excited to see this because we've been really struggling with how can we conceptualize and operationalize what we're talking about for social determinants of health into actual indicators for countries. But yeah, thank you.
Thank you very much, Salma. I can assure you in terms of the WHO, I'm a member of their advisory board in terms of the World Health Report. And also they have a working group on monitoring health equity, and I'm sharing my materials with them. I think Julia also is knowledgeable about that, for the sole purpose that we build on each other work and complement each other. So for WHO, I am comfortable. In terms of University of Australia and World Economic Forum, I will let Shireen maybe tell us if she has use them. I know that you said the World Economic Forum will be published. The University of Australia, if we have not already used it, will be very keen on getting even just the name of the author, anything that, and then we can search the literature. And I also can discuss with Fran Boom and with Sharon Fryer to see if they have any other information. But thank you very much, Salma. Anyone else would like, anyone else first would like to come into the discussion, to the general comments? Well, generally speaking, the general comments, I'm so happy that they are favorable, but we can go now into more specifics in terms of the three important blocks. Let us talk about the structural forces first. I just want to remind you what we did in the structural forces. First is that, of course, we organized the thinking about it. So the whole thinking is we start from the general governance in terms of what is their vision, what is their understanding of fairness. But then we look at specific things that would speak to oversight and accountability, participation, different types of policies, and so on. When we choose the indicators, we were very careful to choose indicators that are likely to manifest themselves in the social structure, and to choose indicators that would influence the performance and capacity and the equity lens of the different public services, and as well as related to culture. So let me invite you. Let me invite you to focus on structural, to comment on structural forces, but I just noticed that Carlos had his hands up and then down. Carlos, did you want to say something and I didn't give you?
No, that's fine. I can speak with, I'm very supportive of the overall work. I have some questions, but I think most of what I was thinking is there's a general impression is how we exactly use this kind of information, who can use this kind of information, where are the mechanisms, where are the opportunities for creating the transformation described by Dr. Rafaki. So I thought that, so that was my main issue. And thinking perhaps of, you thought of climate change in terms of emergencies. But I think there's also, in terms of what are the drivers that could lead to change and could lead to more engagement with social determinants of health. I think there's also the climate crisis itself, and you didn't include that, but I think in the overall framework, but it might be useful to consider the planetary health, eco health, those things which are of concern, which are also drivers, which go beyond the emergency, perhaps.
Right.
They talk of interests of parts of the population, and I think it links to motivation to create change and to drive to equity.
Mhm.
And I think they're very closely related, you know, the health and the ecosystem drivers. And I could see that they were not included as such. You know, the idea of resilience, I agree. And how do we create resilience, not only in the health system, but resilience overall to those drivers? It's a limit in how much you can include, of course. But I think if you think in terms of what could lead to motivation for people to create change and to engage more with equity issues and the kinds of narratives that could be coming out, I think that might be at least to have a discussion of that and say, why is that you're not included at this point in time? Or maybe because you're focusing more on gender and reproductive sexual rights issues. But, you know, I think there should be a place there.
You're right, Carlos. And actually, one of the way to allow us to open up the discussion is to make sure that we share the perspective that these are illustrative, and there are many other things that could be included, and that people need to think about it, because also at the context level, some countries would have very different things than others. You know, the war and the displacement in our region. Well, it used to be only our region. Now I don't know what's happening in Europe. But what I'm saying is it's a way of thinking in terms of making sure you have the big forces represented, like you said. So if we're missing something major, like you said, we should include it. But also is telling countries, this is a modality of thinking, and you have to improve on your system and to try to get as much as information as possible. So thanks, Carlos, and we get back to the future steps maybe after a while.
Sure.
I don't want to, maybe I'm restricting the discussion. Let's talk about feedbacks in general, whether on structural forces, whether on social structures, whether on intervening forces. If you ask my opinion, I'm very happy with the intervening forces, the way that Shireen put it as an entry point to 3 types of domains. So when you talk about the performance, then you're looking at the health challenges, which is the first box. When you talk about capacity, it really relates to the community characteristics. When you talk about the governance of the intervening forces, it really relates, what are you doing in terms of your addressing the social structures or your responsiveness to the social structure. Without taking too much of your time, I just want to tell you that we tried this in data in the Arab region in terms of the health system, and we did find some problems in terms of the responsiveness of the health system to differentiated needs. So there is an opportunity to say something about the fairness of the public health services in that regard. So let me listen to you if you have any comments on the indicators in general, on any domain. So Jocelyn, Jocelyn is also confirming Carlos' point. Does anyone would like to comment on the indicators? Laura, did you say that you wanted to comment? Oh yes, Laura, your hand is raised. This is a new one, right? Okay, go ahead.
Sure, I can start with that as well. Not without first just really commenting on the group. It's an amazing work, and I'm really congratulate all of you and all of us in the field of public health, knowing that your work is going to be really a tremendous help to everyone. A few suggestions or feedback. When you talk about inadequate housing, which I saw it, and I'm not sure now in what bucket was that, which first of all, I completely agree. We need to ask about that. But 2 things, when you said inadequate housing, is there somewhere there that explains what inadequate housing is, just to have everyone on the same page, like what's inadequate? And the second suggestion there is that I noticed that some indicators are like more like in the positive and some in the negative. So for example, just one indicator before that one, you ask about internet. So it's like the number of people who has internet, and then the next one is the number of people or percentage of people that lives in inadequate housing. So one is more like in the, having internet, the other one was inadequate. So I just want to raise that point. Maybe it's easier for the data analysis to have like adequate housing as opposed to inadequate because all of the others are positive. But just for you to consider those things.
Yeah, we can address. Yes, you're right. We should look at that and try to make it consistent. Sure.
Consistent, right. And then the other one was about the workforce, which I just saw 2 indicators in the workforce. So I wonder, what are you thinking in terms of the indicators for the workforce? Because at least here in the States, we're really concerned about the workforce right now, of course. And we're looking at the indicators should go beyond the numbers. Yes, we have to, be sure we have, appropriate workforce in the places. But beyond the number, we are looking at diversity. For example, we need to have the workforce that represents the people from that geographic area that they serve. So we're looking at diversity, and we're looking also at competencies. Do we have the right people? I mean, maybe we can have the right numbers, but maybe it's not the right people in terms of the competencies that they have. And I know that all of this is just adding complexity, but I just wonder if in your reflection about the workforce indicators, what are the main, the main areas that you are concerned, and just adding to the conversation maybe.
We are not trying to answer you in terms of each comment. We will reflect on this very carefully, and this is why we are recording. But of course, at the end of the discussion, I will invite Shireen if she wants to say certain comments on what you're saying, but I'm assuring you that we are listening to what you're saying, and we're thinking of how to address them and how to explain whether we address them or not. So I'm not trying to, not me, all of us, we're not trying to answer specific comments.
No, absolutely, I understand that. That's fine. That are just my reactions, but yeah.
No, that's great.
All of you too.
That's more than excellent. This is what we want to hear, and then we have to think about it and to see how to address it. Salma, you raised your hand, and then Carlos. Go ahead, Salma.
Yeah, sure. So I'll actually start also with the healthcare, of course. And for that one, actually, my question was more relevant to, would you want to get into more details into the specific healthcare force, depending on the topic? So for sexual reproductive health, I was wondering if you would see more indicators on midwives or other healthcare workers, or was it deliberate to keep it as general as possible? Because I think at least for Arab countries, I think I did a comparison between Egypt and Sudan once on mental health, and the different types of workers were it just created different pictures depending on how you're looking at it. So that was the first one for the healthcare workforce. The other one I was wondering about is for the cultural component for gender. I really think that's an excellent one. I was wondering, and maybe this is just the epidemiology component, and I was thinking about and how would policymakers then act on outputs versus inputs. Did you look into the UNDP Gender Inequities Index? Because I think that one tries to look into policies, which would, I think, fit into the structural forces here, but also then looks into education attainment by gender, so that maybe I'm wrong, would that fit into like intervening forces or social structures? And I think I'm thinking about that in terms of would those indicators then be a roadmap for policymakers to act? And if there is no indicator that corresponds from the input to the output, would they be able then to see if the input really has an impact on the output? So even if we have gender equity policies, does that really reflect on like gender disregarded educational attainment or not? I wasn't sure if there's that or not. Maybe I missed it. And I think the last question I had was really, I think a lot of conversation recently have been about whether climate change is a driving force over the next few years. And whenever someone mentions climate change, is usually also tagged with income inequality. And I was wondering if that's something you also considered as a driving force to include in the indicators, just the Gini index or something like that.
Great, Salma. As I said, we're not answering, but I have some reaction, and I may invite Zainab if she wants. But my first reaction when you talked about specific related to healthcare workforce and so on, you are absolutely right. When we get into specific programs, specific SRH, specific even project on SRH, the indicators will be much more specific and adapted to the challenge, and actually to give us room to have the kind of very linked indicators that should appear. So that's, I'm sort of confident in that. In terms of the last comment on the climate change, yes, a key point for us is mainstreaming equity in whatever happens in terms of policies. So if you have a policy on climate change, you will have to look at its differentiated impact on the different groups of society and the structures. So it's built in the whole logic of the framework. In terms of the gender, I love your comment because it didn't occur to me when we talked about the intervening forces, the healthcare system. I was making a point that the way we addressed it is that it manifests itself at different levels. At the final level, which is the health challenges, at the inputs level, at the proximate determinant level. And from what you're saying, any intervention that relates to culture would be the same as the health system. We should look at the policies, but we should look at what happens in terms of the manifestation. In terms of the UNDP policy index, Zainab, do you want to comment or do you want to reflect on it? Because Zainab is our expert when it relates to the gender index. I don't want to put you on the spot, Zainab, but in case you have something to say.
No, I'm just going to say that what we're doing here in the culturally constructed context, that we are trying to capture the gender norms, how gender norms within a specific community is affecting the health of the women and men. So it's more of a collective attitude and behavior of people within the community and how it affects the health. Policy is part of it. So we're trying to capture this collective attitude and try to emphasize that it goes from highly restrictive for women into least restrictive for women. So it's like a culture, traditions, how it affects women. And since culture and tradition is affected by policies, we included part of it, but it's not related to the gender inequality per se. It's the manifestation of these policies at the level of the community, as well as the traditions that's prevailing in these communities.
Okay, let me ask Carlos. It's your turn if you want to.
Sure, thanks. First of all, I should have introduced myself. I'm a medical epidemiologist and I've done clinical and I've been mostly working with public policies, health impacts at the WHO and some other places. And I'm here possibly because I'm the president of the International Society of Urban Health, and we're starting some work to draw on good experiences in creating transformation for health equity. And we're looking for a partner in the Middle East, and I spoke with Hoda about it. So I presume that's part of the link. I'm also sitting on the social determinants of health in WHO. But first, in terms of specific comments, first, I think it's very good to have the intervening forces. I think I really thought it was an excellent idea because the whole set of the working indicators suffers a bit from immobility. And you have all these things which are sitting there and, how do you make sense of where the action is? And I think we're all, and I'm sure that we're all in for the action and what could be coming out of this in terms of health equity. So I think having intervening force, just that sense, where is the dynamics, where are the forces that are influenced, I think is excellent. In terms of the healthcare system and the health workforce, I like very much the fact that you put capacities for social determinants of health, or as people thought about it, have they done policies, etc. But I think what I've seen in a lot of countries, there's still a bit of a difficulty in getting to grips with what does that mean, even with well-resourced countries. We know that we want to work with social determinants. We want to work with other sectors, but what does that actually mean in terms of the workforce that you need within the health sector and the workforce that you need in the other sector? Because in actual fact, the intersectoral action will come through some push from the health sector and some understanding of what the issues are, but from some actual development of capacity within the other sectors. And I've worked many years with energy, with transportation, with extractives. And I think if you don't manage to create that capacity within the other sector, it's very difficult to get change. Same thing with cities. The whole, working with urban planners, etc. See, how is it that they can take up part of the action? So I think I very much the idea of the capacities of the health sector, but I don't think we have yet cracked the ability to work with other sectors effectively. I think it's been very, perhaps in food systems, in some places it has moved, and transportation, you have a collection of good examples. But I think substantially looking at what are the functions of the health system and how the capacities can be developed there, and I would put it more into that sort of open, in an open way. And I would stress that it's not enough to have those policies because they can mean lip service. We see that with climate, with other policies. We have a policy which is written up. Is anything happening on the other, in the implementation side? So perhaps as a way forward, reflecting more on that and developing the implementation of those indicators along with the health system, and maybe not call it a healthcare system, but we just call it health system, or to include the public health part, because it's not only about healthcare, it's about the core public health functions. But I certainly appreciate very much what you're doing there. I think it's very ambitious. But in terms of moving forward, if you can engage with some of these other sectors, for example, to see how they could use these indicators, what indicators do they have, and the process of moving forward, I think would involve some discussions and debates and cross-fertilization about people who are working in the other sectors. And I see that as a very fruitful, because you're going deep into what you see are the issues in health equity, and that helps you to establish conversations. But the conversations, I think, it would necessarily be part of the getting to the transformations that lead to health equity. That's a step. But in essence, to have this intervening force, I think it really makes it very so. And I would be curious to see what the World Economic Forum is doing, because of course you have to understand what businesses have, as well as civil society and other groups in their mind, and can they use these indicators, etc. So congratulations. It's a long way of saying that I really like what you're doing and the fact that you're moving that direction.
Well, Carlos, I could not agree with you more actually in terms of your emphasis and your concern with the mindset, because I'm like you. We are technical people and we provide the indicators and we have a logical way of, and we know that they're important, but the buy-in is really very difficult to obtain, particularly at the policy levels. And whenever you talk about social determinants of health, people feel that they know it. I mean, I remember a conversation with the Minister of Health, and when I was talking to him about this whole SDHE, and he simply said, well, but we know that, Huda, this is old, and we have known that since, the early WHO years. But the difference is that they decide it's not their business. This is not their business. This is the development sector business, and the healthcare or the health business is different. So I fully agree with you. We try to do workshops. It's not this kind of work. but we try to do workshops, and more people are hearing, but not enough at the policy level, like you're saying. So, yeah, fully supportive of your appreciation of the constraint. And this may move us to the future steps. But before I do that, are there any comments in terms of the indicators themselves that you want to share with us now from any of our colleagues?
I think there's things which are on detail. I can send in writing. I mean, for example, disability is more functional capacity, depends on the environment where you're sitting, what the courage, how to capture those. I can send in writing.
Right. I was just going to say that actually. I was going to tell our colleagues, if you happen to have comments you want to share later, please do. I mean, our problem is, how busy you are, and we don't want to impose on your time. But if you feel like sharing even in bullets without investing too much effort, please do not hesitate. And also, I know there are several of our experts that did not join us, so I will be sending them requesting if they can share their comments. So let me move quickly because the time is running. We only have 15 minutes left to the point of future steps. I'll tell you in terms of the project, what we are planning to do. As Jocelyn said, as a project, we only chose, and we chose very carefully, Morocco and Jordan, because there is an appetite there. There is an appetite for equity, there are data, and there are colleagues very competent and willing to collaborate. So what we plan to do is to hold what we call is a stakeholder meeting in the country. And what we mean by stakeholder meeting is to have a wide meeting with many participants from different domains, not just the Ministry of Health, under the auspices of maybe a development sector, Ministry of Social Affairs sector, Minister of Health. And in that meeting, in a way, we're repeating the presentation we made now, the description of the project and the description of indicators, and encouraging people to start looking at their data and to see how much they can utilize the ones we are proposing, and what are their needs to be able to utilize it. That's in terms of a general information dissemination meeting, and then we'll put all the data also on our SRC platform that there is no time to talk about now. However, the more concrete step is that we are trying to identify in each of those countries an actual intervention. So an actual intervening force, Carlos. We want to know of a program that is attempting to improve SRH, or even modestly wise attempting to address early age at marriage, or to address female genital cutting, or whatever. And we want to work for a whole year very closely with that program by reaching together a detailed list of indicators specific for the activity they want to do, and making sure that they're not following a biomedical model, making sure that they are talking about policies, not just the behavioral change, making sure that they have specific goals and they have indicators of success, and across the year to work with them closely and produce the free outputs. That's our kind of humble future steps that is incorporated in the project for next year. Of course, we are very much hoping that by liaising with you, by disseminating what we're doing, is that we get others who are interested in this kind of work, and we join forces together and make a more kind of important impact. But ours is, one step at a time. So I'll open the floor to ask you if you want to make a comment on the future steps. We have 10 minutes. Before I open the floor, just to give a chance to Shireen in case she has a specific reaction to one of the comments, because this covers the first two parts, the general impression, the feedback. Shireen, do you have something specific you want to say, or let's together reflect on?
Just very quickly, Dr. Hoda, I would like to thank everyone for their comments, really very helpful. And please, if you feel when we finish this meeting, if you feel that you have something to say about the framework or about the indicators, please write them back to us. We'll really be very grateful for that. I just want to comment on Laura's comment. Actually, Laura, you're right. We need to have the indicators consistent in one direction. And we have done this in our application on 5 Arab countries, that we had all the indicators in one direction. But here we were just copying the indicators as they are in the SDGs or in the Emerald list, just to keep them and to say that we're not inventing something new. These are the ones that are there. But maybe in future we should think of making them consistent. The second thing, for the workforce, and not only for the workforce, for many other indicator domains, we were really hesitant. Should this be in a national basket of indicators, or should we put the details in the program level indicators? And what is exactly the cutoff point? When should we put in national indicators, and when should we put them as additional indicators in program levels? This is something that we're still discussing, and we are also looking for your feedback on that. I have just one comment to say. You focused on the framework. This is very important to have. You focused on the indicators, but there is something, and Dr. Hoda will always, she always accuses me that I'm getting this point upward, is that you did not say anything about the summary measures. The summary, the overall, we are all working with overall measures. Despite that, the commitments look for disaggregated data. And we, in our work, we are proposing a third type of measure, which is the distributional measure. And this is something that we really should all think about, because the distributional measures are the only means to help us say or judge if this is fair or unfair. So please, if you have some time to just think about our approach, think about the three of them. Think about the framework, the indicators, and the summary distribution measure. And thank you.
I see Nazar got encouraged. Go ahead, Dr. Nazar. You're muted. You have to unmute. I'm not sure if this is an old hand. I think it's a new hand. Nazar, are you with us?
Yes. Sorry. Thank you very much. Thank you very much. And I just want to add like 2 points for the future directions. And I'm quite sure it is in your mind, but because I have attended the previous workshop and I also enjoyed the presentation of Dr. Shireen. So when you organize this workshop at the 2 selected countries, I guess while this framework or the conceptual framework is presented and its outcomes, also it's better during the presentation to give like some sort of examples which will be easy for the audience to understand what do you mean by each domain out of the framework. Because without giving examples, as you mentioned, Professor Huda, everyone will say that we know it and we understand it. And actually they are almost totally ignorant about the subject itself, but they assume they understand. So this is one point, and I hope it will be valid for you. And the second point about the issue to be selected also, and I add my voice to those who commented, if the topic which will be selected in each of these 2 countries, that we can make sure all the stakeholders are concerned about this subject or the topic to be selected, apart from those who are working in the health sector. I guess this will bring more people on board, and this buying in, which we are aiming at, will be materialized more. But if we select a topic, for example, that is only the concern of those who are working in the health sector, and I mean the other sectors, they will feel that they are just like comparse in this training or in this exercise. So these are my 2 comments, and over to you.
Those are excellent comments. Actually, we were going to fall into the trap. I was going to focus on one group working on SRH, probably to be from the Ministry of Health. And it wasn't very clear in my mind at the time. Now it's clearer. We cannot work with them alone. We have to have the other stakeholders on board, even on a program level. I was thinking of the other audience on a stakeholders level, but you are just right in terms of this advice, and we'll take it on. Thank you very much, Dr. Nazar. Anyone else would like to say any comments on future steps?
Maybe just add, and again, it's just a suggestion or just something that just to think about. First of all, I think it's a great idea just to implement it in 2 countries right now. And I think it's great. You're going to learn a lot by doing that, that strategy. And I think it's very important how you're going to unfold like the whole project with both countries. I will be very much interested to know the reactions of the stakeholders in order to learn from that and just to, to continue your work. But maybe 2 things that you could do. One is just, of course, to just, release everything that you have done, and let's see in this complexity how they react. But the other one is just to release in it, but maybe a little bit of work in what will be the basic indicators as opposed to the more, the entire indicators, to see if they react to that better in terms of, I just maybe try to caution about the complexity, and I would like the stakeholders not to be like, oh my God, this is just too much, I cannot do it. It's just like, yeah, this is a holistic approach, but maybe you want to start with these basic ones, and then, you are whatever you want. I mean, I'm just trying to see what will be.
Laura, you are on the spot, actually. What we should do before putting the indicators in is putting the big blocks, the big dimensions. And then we start, like Nazar told us, give examples and not to pretend that we are making the complete list. We are following a line of thinking in terms of that, the way to develop your own list. Really, all your advice was very valuable. We have a newcomer, but I will not give her a chance to talk. Shireen Hussain, our dear colleague, but she got confused about the starting time. Because we finished now, but what we're going to do, we have recorded the session, and with your permission, we will post this recording on our site. We will communicate with our other colleagues who were unable to attend, and we'll ask them to comment. And this includes, of course, Shireen Hussain. I noticed that, Carlos, you had your hands up. So if you want to—
It's just another brief suggestion. I mean,
yes, go ahead.
You may want to discuss this range of indicators with people who work with communications, with either health journalists or development journalists. You may want to have some kind of exploring, because you see how people would use this, what kind of things do they think could be more engaging, or what. So talk about the narratives along the indicators, rather than only, I know that you have to work, and you should be working with Ministry of Health, but it might be useful to take somebody else's perspective in terms of what are the conversations that would link to the kinds of indicators that you're developing. Because as there's a long list of indicators, you would want to find ways of starting conversations, right? And that's one of the ways that you could perhaps do it.
And actually, we can also turn it into illustrative example of data. We have some data that we can, it's not in the project. This is the problem of people like us who are working on deliverables and that kind of things. But I think it makes a very good sense to try to have an to apply what we're saying with real data, and to show what it tells us. We have done a modest exercise on SRH, and we have a report on that, but maybe maybe so people can get a feel of where how useful this will be for them. And then maybe, like you said, Carlos, invite the other journalists and the other interested people. I have to close because it's 5 p.m. I know that Hussein is dying to come in, but I'm really sorry. Sorry, Shireen.
No. I just say I'm really sorry. I got it wrong in my calendar. I was really keen to be part of it, but I'll watch the video. No problem.
I'm sure, and we will be working together. In closing, and I will give I'll give it back to Jocelyn. In closing, I really would like to tell you, we would love to collaborate with you in your work. You collaborate with us. Do cite our work and feel free to use it as you want. I see also Richard. You just joined us, Richard. We started at 3. Maybe there is a confusion again, like Shireen. People living in England have a problem with the time difference. But I'm sorry to have missed you, but I'm obliged to close the meeting. But as I said before, maybe you joined us, Richard. If you have comments, and I will share with you the recording of the session because it's from 3 to 5. Jocelyn, do you wanna close the session? But thank
you so much, everyone, for really active engagement and excellent suggestions and contributions, and look forward to continuing the discussion. Thank you so much, and thanks to the SRC colleagues for all the hard work.
Thank you.
Thank you all.
Bye now.
The start of our relationship. We'll work again together.
Thank you.
Thank you.
Okay. Bye.
Bye.
Bye.